Hi, Dr. Chinmay. We can start now. Thank you.
Yeah, sure. Hello, everyone. I'm Dr. Chinmay, and I'd be the tutor for your seminar today. I hope you all are doing well. And before I start the seminar, I can see the people are joining in. Can you all first give me a quick heads up, like who's got exam like in February or March, like who's got the exam in like very recent future, so that I can have an idea about. Okay, one has got in the mail. Okay, Dr. Sid. Okay, so that means we've got like a good enough time. Anyone who's got the exam in Feb or March? I'm so sorry, I'm not so very updated with the schedule for the AMC. When are they going to start the exams in the Feb? Is it already started or are they going to start it now? Okay. I can see March. Okay, so one has got it in the March. Okay, hope you're doing well. Hope you're doing your preparations is going well. Okay, and like in the last minutes of our session, um, we will we'll be covering all these questions and queries that you might be having. We'll have an open floor for the questions, so like I can answer the questions that you might be having till then. Okay, anyone else? Anyone who's attended my lecture before, like my regular lecture or my crash course before? Any lecture before, like, or everyone's new over here? And the reason I'm asking this question is so that I can see some doctors who I've seen the name of. I can see some familiar names, but apart from that, so that I can have an idea about how I'm supposed to carry out, because I would just want to know my audience as of now. Yeah. Okay. Then let's start. Okay. Hello, welcome again, everyone. Okay, so what we'll be doing today is we'll be doing the certain recent medicine recalls for the people who would have joined the recall crash course that I did in the month of December for the month which was very recent recalls for the medicine. Okay, you will see certain transcending questions because those are I've taken about 15 to 16 questions in this session today, and all of those questions would be like very important topics, so it won't be just me solving the questions, but at the same time you would also be having a revision for the important topics, right? Which is mostly it's getting asked in the exam, right? So that is also for that. So let's go for the first question for today. A man with an history of claudication at the 100 meters and pain in the left calf relieved by the rest. On examination, there was a weak left femoral pulse and absent dorsalis pedis pulse. Okay, ABI was done and it was 0.25. Okay, the normal range is given to you. It is 0.9 to 1.2. Pulses on the right limb are normal. What is the most appropriate investigation leading to you to the diagnosis? Okay, any answers, any prompting? What is your answer? Should it be arteriography? Should it be CT angio? Should it be compression Doppler ultrasound? Should it be MRI or should it be an X-ray? Okay. See, whenever it comes to the AMC, I'll be coming to this. Well, when I'll be giving you the sharing you with the tips for the last minute tips for the examination. Okay, but be very very conscious about what are they asking in the question. Okay. Yeah, I can already see the answers rolling in. They're asking it what is the most appropriate. Okay, most appropriate investigation, not the next line investigation, not the most commonly done investigation. Okay, they're asking is what is the most appropriate investigation. Okay, so I can also say what is the gold standard investigation. Okay, which would give you the investigation which is most sensitive, most specific. Okay, it's a perfect in all terms. Yes. So over here, Dr. said I think I has got the answer correct. Okay, others, some people are saying B, some are saying C. The answer over here is arteriography. Okay, answer over here is arteriography. But first let's, okay, so what are we doing right now would be the peripheral arterial disease. Okay, and I can see like no, this is a little bit of a confusing question because this is firstly a very commonly asked question. Okay, so what happens over here is that what you're supposed to look at is first is the ABI. There is something called as the ankle brachial index, ABI. Okay, so if you guys will be knowing, it's actually we check for the blood pressure at the level of the ankle. Okay, ankle and the brachial plexus. Okay, the brachial shoulder area, and you will compare it. Okay, you make a ratio for that, and that is how you get an ankle brachial index. Okay, so what is that? I've given to you the normal ones is 0.9 to 1.2. Okay, and if it is less than 0.5, then it shows a critical limb ischemia. Okay, then it shows critical limb ischemia. right? And so here what they're saying is that ABI is 0.25. That means it's severely reduced. It is in the state of the critical limb ischemia, right? And the weak femoral pulse, and you can already see the absent dorsalis pedis pulse. So it is already in CLI, right? So on that basis you can confirm the diagnosis. So what they ask is, if they ask to you, okay, I'm not here to give you the correct answers, I'm here to give you the approach. If they ask you what is the first line assessment, okay, what is the first line investigation, what is the next line investigation that you'd be doing, over there your answer would be the ankle brachial index, because it's an office test, right? It is something that you can, just do it, like you don't have to do nothing that's invasive. It's a very simple test. It is as easy as measuring the blood pressure, okay? But next best imaging, if they ask to you, right, it is CT angio or MR angiography. They are the non-invasive options, okay? Compression Doppler ultrasound is also used, but that is for the initial screening, right? But over here the gold standard would be the arteriography, okay? The gold standard would be the arteriography. I also would be including a table which they've given to you in the RSCGP guideline, right? So that is actually an arteriography. What is another word for that? Okay, sometimes they use this word, which is a digital subtraction angiography. Okay, so what they actually do is they're doing the angiography, right? And the digital means, it's a digital, what we have in the digital X-ray, right? So subtraction means of that very specific part, right? So whatever we want to look at over that area, it's a very definitive test, okay, in which you can completely see the vascular anatomy, and then you can plan your intervention accordingly. Okay, that is how it goes, right? So conventional arteriography or the digital subtraction angiography, it is a gold standard investigation, most appropriate investigation. But next line, first line assessment, if they ask, it is an ankle breaker index. Okay, someone said, because I knew that someone would be getting confused between the CT and angio. Okay, so why not CT and angio? Okay, you can actually use this. There's nothing wrong with the CT angio. Angiography, okay, we also use it in the ischemia when it comes to heart. Okay, when it comes to the muscle ischemias or anything, CT angio you can use, right? But it's actually a pre-intervention planning. In that basis, you can actually use this. Okay, but arteriography, okay, it is very specific. Okay, it is very specific. You can very specifically you can look at what is the flow of the blood, okay, and where exact site can you see the occlusion. So it is actually better. Okay, so digital subtraction in geography, it is always better option than to go with just a CT in geography, right? Because the process and everything over there is different, right? So always prefer to go with the DSA. If the DSA is not given in the options, then you can go with the CT angio. Okay, sometimes the AMC would play with you. Okay, so sometimes they may not give you the option, which is please try to remember both the names, arteriography or the digital subtraction angiography. Both the things are same. But if that is not given to you in the options, then what you'll be going with? You'll be going with the CT angio. Okay, so this is actually the guidelines what they give it to you in the RSCGP. Okay, and I have concised it for you, right? So all of us knows that smoking, diabetes, hypertension, hyperlipidemia, all of these are the risk factors for the peripheral arterial disease, right? And what the common symptoms, what you see it is an intermittent claudication, leg fatigue, rest pain. Okay, in the advanced PADs, you did what you see the rest pain. Okay, there is one very specific physical examination. What you do it is the Berger's test. Okay, Berger's test, in which you're just simply elevating the limb, and you can see the pallor on elevation, and when you just put it down, then you can see the rubor, right? So there is some test that you can remember. That is what is given to you. But the screening is not routinely recommended in Australia, right? What they give it, so if the patient presents to you with such specific symptoms, then you can go with the ABI. Okay, but for the patients with the hyperlipidemia or anything, there is no such routine screening guidelines. I think this question was asked once in 22 or 23 regarding this. That what is the routine screening guidelines for the PAD? Okay, it is not so. It doesn't exist. Okay, PAD, everything I showed you, the first line diagnosis is the ABI, which indicates okay less than zero point 0.4 or 0.5. What you can see, it is a critical limb ischemia that you're supposed to remember, right? And other investigations they've given to you the duplex ultrasound, the CT angio, the MR angio, but the digital subtraction angiography, it remains gold standard. Okay, this has some differentials that is given to you. Okay, DVT, the neurogenic claudication that you would be knowing, the spinal stenosis, what you would name, the red flags I've given to you, right? That there is a 6P. Okay, you guys will be knowing about this from your med schools days, right? The 6P for any peripheral arterial disease, it is pain, pallor, pulselessness, paralysis, paresthesia, and poikilothermia. Okay, so such symptoms will be given to you in the questions, right? The main management is the smoking cessation, exercise therapy, dietary modification. But here you have to start with the pharmacological treatments. And what is that? It is antiplatelets. Okay, antiplatelets, statins, S inhibitors, ramipril, antihypertensives, all this, right? And the vascular surgery and everything that is given to you. That is not very much important, but you can remember that bypass surgery or the end arterectomy, these are the surgical options for the critical limb ischemia, right? Please keep that in mind. Okay, with that, let's move to the next question. Everything's clear? See, if you guys have any doubts, and I have already activated this on my phone as well, so I can see your chat section. So just put your question in your chat, and I'll try to respond it as soon as I can. Okay. Next, let's come to the next question, which is a 27-year-old woman who presents to the ED with a high fever, diffuse macular rash, and a hypotension. Okay, she reports experiencing severe myalgia, vomiting, and diarrhea over the past 24 hours. On examination, her temperature is 39.8 degrees Celsius. BP is falling right now. It is 88 by 50. Heart rate is 120. Mildly tachycardic, and she has an erythematous mucous membranes. She mentions that she has been using the tampons during her menstrual periods, which shows that it is simple, right? There's not a significant history with that. But let's come to the lab results. WBC, it is 16,000. Platelets is okay. It seems okay. Create is 2.1. Okay, ALT, AST mildly raised. And creatine kinase, it is 600 unit per liter. Okay, so first you guys tell me what is the diagnosis right now? What is the diagnosis that you can think of? Yes, Dr. Lumayo. Guys, please try to mute your mics. Uh, it is the toxic shock syndrome, which is caused by what? Caused by what? Toxic shock syndrome. Yeah, it is caused by what? Staph A. Yeah, that's true. That's true. Staph A. I'll just meanwhile. Okay, it's over. Yeah, so it is a toxic shock syndrome, which is caused by a staph A infection. It is a staph A infection over here, where you can see it right now. Okay. Yeah. So let's come to the. So what is the most appropriate investigation? Next step in the management now. What you should be doing? Tell me the answer now. It's very good you guys came up with the diagnosis. First is administer IV fluids and empiric antibiotics, which is Clinda plus Venco. Administer IV corticosteroids. Perform an emergency CT scan for abdomen. Prescribe oral antibiotics and discharge the patient. And order a blood culture and wait for results before starting the antibiotics. Hmm? Yeah, I think it's a fairly simple question. I think the main challenge over here is the diagnosis, right? But that doesn't seem to be the challenge over here. Okay, your answer over here would definitely be IV fluids and empiric IV antibiotics. Okay, it's a classic case for the toxic shock syndrome, right? What you can see here, you can see the erythematous mucous membrane, the high grade fever, right? And it is also following an infection, right? So mostly it is because of its staph aureus exotoxin production, right? It's a rapidly progressive life threatening indication, right? So it demands the urgent intervention. The first step always and always in this, it would be an aggressive IV fluid resuscitation and give a broad spectrum antibiotics. Okay, and most of it would be the antibiotics which would be working for the anaerobic bacteria, which is the clindamycin as well as the vancomycin, right? Right, so because there's the other options, it actually doesn't make any sense. So it's actually a fairly simple question, right? But this is something, the toxic shock syndrome symptoms, which you should keep in mind, which is actually a high fever, right? Rapid drop in the blood pressure, which you can see it over here, the confusion, diarrhea, fatigue, low urine output, okay, the overall muscle pain, okay, there is a myalgia, which comes with the red eyes and the sunburn like rash, which is the erythematous rashes that you can see, the vomiting, weakness, and the lethargy. Okay, that is something that you should keep in mind, right? This is the toxic shock syndrome symptoms. Okay, let's come to my favorite topic, which is serious. 45-year-old man presents to the ED with a sudden onset of palpitation, chest discomfort, and lightheadedness for the past 20 minutes. He denies syncope or previous episodes. He has a history of hypertension for which he takes amlodipine. On examination, he is diaphoretic with a heart rate of 180 beat per minute. Blood pressure is 95 by 60. Respiratory rate is, okay, blood pressure is tachy, I'll just highlight that as well. Respiratory rate is 18 breaths per minute. ECG shows a wide complex tachycardia with a regular rhythm with no peaceable P waves. Okay, I'll also show you the ECG. What is the appropriate initial management for this patient? Here's your ECG. This is your ECG. Okay. Okay, what is your answer? What is the diagnosis of here? First, make the diagnosis. I think in the recall, I think the ECG. Don't just focus on this one ECG, not what was given in the question, right? What is your diagnosis on the basis of the ECG? What do you guys think of right now? What are the differences that comes to your mind when you look at the ECG? Okay, what is it? SVT. Yes, it's actually PSVT. So what you can see it right now. Okay, it is actually the narrow complex tachycardia. My bad, it was not given that. It's a narrow complex tachycardia, right? Narrow complex tachycardia. Why? What is it? PSVT. What is the finding? Okay, I'll come to it. I'll give you the differentials, how to differentiate between all the types of the arrhythmias. We'll have a quick discussion on that, right? But what you can see is there's an absent P wave. Okay, the P wave is, it seems absent. Okay, you cannot see any P wave. Okay, there's actually QRS complexes, which is narrow, less than 0.12 second or less than 3 small boxes. Okay, so normal QRS complexes 0.122, point 2, right, which is 3 to 5 small boxes, right? So it is definitely lesser than 3 small boxes, so it is actually a narrow complex, right? And on the top of that, the P wave is also absent, right? And you can definitely, you can appreciate a tachycardia. So it is nothing else but a supraventricular tachycardia. Okay, so depending on this question, what is your most appropriate management, initial management for this patient? Should it be IV amiodarone, IV adenosine, immediate synchronized decardioversion, IV MEG self, or observation and follow up? What is your answer here? Okay, guys, waiting for your answers. Amiodarone, one is saying synchronous cardioversion, someone is saying B. Adenosine. Okay, I can see B and C. More prompting, more answers. Okay, B or C. Okay, most of the people are going with C. That means that you're already good with the concepts for the arrhythmias. That's very nice. That's very nice to know. Okay, see here for the first rule for the arrhythmias, right, which you should keep in mind is whether the patient is hemodynamically stable or unstable. That is what you should keep in mind. Okay, and this is where this is actually the arrhythmias is one of the most favorite questions for the EMC, right? So what they give you is then most of the people will be prompted to go with the adenosine because it's an SPD. Yes. Okay, that is what happened with I think 3 or 4 or 5 candidates over here, right? They answered adenosine, right? But you have to look at over here that the patient is actually clinically unstable. The BP is 95/60, already tachycardic, okay, and there is chest discomfort and everything. But what you can see to it is the patient is already hemodynamically unstable. Patient is already hemodynamically unstable, right? So there is no point of giving the adenosine right now. It is not effective over here, right? So it's an unstable, so you have to go with the synchronized cardioversion. Okay, you have to go with the synchronized cardioversion over here. Okay, actually, this is what they give in the this is what was there in the recall. Okay, I checked it for twice or thrice, right? But when the patient if loses consciousness, actually the defib would be a more better answer. Okay, defibrillation. That is what you should be going with instead of going with the synchronized cardioversion, right? Right, so that is what you should be actually going with. Okay, the defibrillation would be better, but what will it be? Actually, it is an electrical cardioversion that you should be doing. That is the answer over here, right? So first, let's see, just quickly discuss the ECG based classification for the tachyarrhythmias. So what you can do it over here is firstly just look whether it's a narrow complex or the broad QRS complex. I just told you how to look at whether it's a narrow complex or the broad complex, right? So if it's a narrow QRS complex, that means it's a supraventricular innervation. If it's a broad QRS complex, then it's a ventricular innervation, right? So see, this is how you would look at it. Okay, what first is QRS complex, second is RR interval, and third is P wave. Okay, in the cases for these things, always and always look in this format. Okay, QRS complex, RR interval, and the P wave. Right, first see whether it's a broad or narrow, then go with the RR interval, whether it's a regular or irregular, right? And then you look at whether we can appreciate the P waves or not, right? So next, let's come to the regular. So if the RR interval is regular, okay, what you can see, then it's a PSVT. If it is an irregular, okay, narrow QRS complex, irregular RR intervals, and absent P wave. Then third is we look at the P wave. The P wave is absent, and what is it? It's nothing else but an AFib, okay? But blood pressure stable? No, no, blood pressure is not stable. It's already 95/60. How can you see the blood pressure is stable? See, PSVT actually, it's in the pediatric age group and in the elder geriatric age group, it is actually fairly common, right? Sometimes you can also see it in the athletes. Okay, so most of the patients, okay, if you look at the reports and everything, most of the PSVT patients, they are actually when they present to you in the emergency department, those are no, those are actually no. You have to look. The BP should be normal. Okay, what you're saying for the 90/60, that is actually for the hypovolemic shock, that the patient is in shock. So if the BP would have been there, the patient might be unconscious, right? So most of them, the PSVT patients, when they come to you, the BP is actually normal. Hmm? That is what you have to look at. The PSVT patients, the BP is actually normal over there, right? So if the BP is abnormal, if the BP is falling, then you have to consider hemodynamically unstable. What do you understand by hemodynamically unstable, right? It's nothing else but it's a pulse. It's your pulse, it's your blood pressure, your oxygen saturation, your vitals, right? Hemodynamically mainly means it is your pulse and your blood pressure, right? And if those is one is the tachycardic, and obviously it will be tachycardia, right? Because it's already in the SVT. But if the BP is abnormal, then you have to consider that patient to be hemodynamically unstable. Okay, because that patient, the PSVTs, they they can very quickly transform into what? Into ventricular tachycardia, and then you want to be able to, stabilize the patient. Okay, the stem talk. Yeah, that's what I said. Actually, the ECG, what was said, it is wrong. Please consider the ECG picture which I gave to you, not this one. Hmm? The ECG shows this one. I think I made a mistake with it. I took it directly from the recall, and I think it's a recall or mistake or something. And it was already there in my file. Okay, please consider the ECG which is given to you, which I've given to you in the question. Okay. Yes, Doctor. Which one is it? Is Doctor Lumayo? Is it clear for you? Okay, so as I was talking, okay, so absent PV means it's an atrial fibrillation. If more than 3 different PVs, it's an multifocal atrial tachycardia, right? And if it's a broad QRS complex, okay, and then again you look for this regular R, irregular R interval, broad complex, regular RR interval, then it's a VTech, okay? And if it's an irregular RR interval, okay, then it would be no identifiable QRS complexes, it would be VFib, and the VFib, the patient will always be unstable, right? You have to quickly go with the defibrillation, right? Can you please open any reference for bilateral by 60 instability, RSC, GP, or any? Not right now, but I can send it to you in the group after we're done with the session. See, 90 by 60, what you're talking about, yes, is actually, it is there for the shock. It doesn't apply over here. It is as simple as hemodynamically unstable the patient should be. Okay, what are you talking about the 90 by 60? So in that patients, you had to actually start the patient on the vasopressors as well. Okay, you have to manage the blood pressure there as well, right? If the BP is abnormal, because it is fairly common, trust me when I say that it is fairly common for the blood pressure to be normal in the PSVT patients. In the PSVT patients, it is fairly common, okay, that the blood pressure will always be normal. Yeah, it will be somewhere around 120, 130, right, somewhere around that. If the BP is less than 100, the systolic BP is less than 100, that means the patient is unstable, right? And you have to start the management. Okay, that is in your regular practice as well. What do you do for the patient who's got the BP which is less than 100? Okay, you start them on the fluids, right? You start them on the noradrenaline if that is required, right? Depending on whether it's in heart failure, what kind of shock it is, right? So for less than 90 by 60, I can understand where you're coming from. That is actually for the cardiogenic shock, or the hypovolemic shock. For that we use the stem for less than 90 by 60, right? But yeah, I can send it to you. I have one article for that, and I can send it to you in the group after we are done with the session. Okay, and if it's a 3 different QRS complex, it's a torsa-disc response in which we have the sinusoidal pattern. Okay, in which we have the sinusoidal patterns. Okay, for the people who already taken the lectures over here, I have just described in great detail about all the types of the arrhythmias, how to identify them in the ECG, and what is the management for that. Okay, but as of now, always just keep one thing in mind, right? That for any kind of arrhythmias, if the patient is hemodynamically stable, then go with the medical management. Okay, the medical management it varies. Okay, for the PSVT is adenosine. Okay, for the white complex tachycardia it is immunotron. Okay, it is immunotron. Right. Also for the, if you guys know about the ACLS algorithm for the acute cardiac arrest algorithm, right? And that also, if it is an shockable rhythm, if it is in shockable rhythm, what is the shockable rhythm? Which ventricular fibrillation or pulseless VT, right? In that also you give immunotron, right? But if it is an unstable patient, then always and always shock. Okay, and you actually mostly you prefer over would be a defib, right? It would be a defib, right? Okay, so yeah, this I think you guys will be knowing about this SVT patient. Okay, hemodynamic unstable. Okay, cardioversion DC shock always, right? It is simple over here. It's given in this. See, this I've taken from the guidelines only, right? It is hypotension. Okay, hemodynamic unstable means hypotension. Adenosine then immunodron, right? Shockable. No, Dr. Pshita. What I'm saying is, okay, first let me finish this. Okay, then you go with the cardioversion. If the patient is hemodynamically stable, then these 3 steps where we do, right? First, you go with the vagal stimulation, which is the carotid massage. Okay, but now they started doing the modified Valsalva maneuver. I think you guys would have seen this videos everywhere. I'm not added over here. Actually, in the recent RCGP guidelines, I've removed the carotid massage. Okay, so you can skip on that. But what you do is the modified Valsalva maneuver. Does anyone know what you do it in the modified Valsalva maneuver? Right? Valsalva everyone knows. Okay, what is modified? What is modified Valsalva maneuver? Patient supine. Yeah, that's when you just raise up the legs in the air of the patient and very quickly. First, you give the Valsalva. Okay, first you can give them the empty syringes and everything for them to exhale out in it, right? And then you very quickly make the patient go supine. Okay, so this will give you more often than very clearly, the BP stabilizers. Okay, the tachycardia which is there, sometimes toxic tachycardia like more than 200, more than 220, it would settle down in just less than 1 minute. Okay, then no response, then you go with the IV adenosine. Okay, and if still no response, sometimes they go this further. Okay, they've given already 2 shots with adenosine, what they should be doing now, and the patient is already stable, right? So there's no point that you cannot shock the patient. If the patient is stable, if the patient is conscious, you can't shock the patient, right? Still no response, then you go with the CCBs and the beta blockers. So I think if you know about the William Walk classification of the antiarrhythmics, we have 5 classes of the antiarrhythmic drugs. Okay, 5 classes of the antiarrhythmic drugs we have, right? So one is the sodium channel blockers, three is the potassium blockers, right? And 2 and 4. Okay, 2 is the calcium channel, 4 is the beta blockers, and 5 is the class 5 is the adjuvant drug, which is Maxulf or adenosine. That is class 5. So those are 5 classes of the antiarrhythmic drugs, right? So if the IV adenosine is not working, then you can always and always go with the calcium channel blockers or the beta blockers. Remember, these 2 drugs, it is not only just responsible for the rate control, right? But it has also got the anti-arrhythmic properties as well. Okay, yeah. So what someone was asking in the question, and neodron, it is for the wide complex tachycardia that you actually give it in the ventricular tachycardia patients. Yeah, ventricular tachycardia patient or torsades pointus patients. Okay, but one more thing where you do. Okay, what if I ask you? This I've covered in my lecture. I also want to cover right now. A patient, they give it to you in the ECG for the torsades pointus. I hope you guys will be knowing how the ECG for a torsades pointus looks. It is nothing but it is just a wide complex tachycardia. It is VTAC only, right? But is what is a monomorphic VTAC. Okay, VTACs we have two, monomorphic and polymorphic. So monomorphic VTAC, okay, and that we have the sinusoidal patterns, right, like this. Clearly, you would be able to see it in the ECG. That would be a torsades pointus. Okay, so in this way, you can actually identify it's a torsades pointus by the ECG. Now I'll ask you 2 questions. What is the next line in the management of the torsades pointus, and what is the most appropriate management? What is your answers now? This is A, this is B. What is A and what is B? Okay. Next line management for the torsades pointus, and what is the most appropriate for the management of the torsades pointus? Yes, Dr. Ripshita, very nice, right? Actually, next line in the management of the torsades pointus is Maxulf. It is Maxulf, right? What is the most appropriate right now if they ask? Amiodarone. Okay, amiodarone, always. So Maxulf and then amiodarone. Very right, Dr. Gotham, right? So for the torsades pointus, please remember these things because Maxulf is also the class 5 antiarrhythmic drug, adjuvant drugs, as I just said. Okay, Maxulf, then adenosine, okay, verapamil, no, not verapamil, it's calcium dopamine. Maxulf and the adenosine, these two are your adjuvant drugs, right? So in the TDP, next line, Maxulf, and appropriate would be the your amiodarone, right? And for all the wide complex tachycardia, you give amiodarone, except for the ventricular fibrillation. Okay, in the ventricular fibrillation, you have to directly go with what? Cardioversion, right? Because in the ventricular fibrillation, those patients would never be stable. Okay, those patients would have lost the consciousness, would have lost the BP, it would be a pulseless one. It would be a pulseless one. Okay, so this is actually ACLS algorithm. I think I've included it somewhere else. Okay, yeah, in this question only. So first, let's discuss this question and then I'll show you the ACLS algorithm because they do ask questions from that as well. Let's come to this question now. A 62-year-old man collapses while attending a family gathering. Bystanders initiate the CPR immediately. Paramedics arrive within 5 minutes and find him unresponsive, pulseless, apnea. The cardiac monitor shows ventricular fibrillation. Okay, this I'm just giving for the question purpose. Okay, they would never give it to you in the this thing in the question. Okay, they will always give you ECG. Always and always give you ECG. Right? Paramedics deliver a defibrillation shock because that is what we do for defib for the VFib. First thing, defib shock using a biphasic defibrillator and resume high quality CPR for 2 minutes. Right? A rhythm check reveals persistent VF, means they've still not recovered the pulse. A second shock is delivered, followed by a continuous CPR. After another 2 minutes, the rhythm remains VFib. Okay, and the paramedic administer the IV epinephrine as well, right? Because it's cardiac arrest. At the end of the day, it's a cardiac arrest. So you can never forget what adrenaline. You can never forget your epinephrine. Okay, CPR is resumed, but the VF persists on the 2 rhythm check. Upon arrival at the emergency department, the patient is still in VFib despite additional defib attempts. What is the appropriate next step in this management? Administer IV immunodrawn, perform emergency coronary angiography, initiate therapeutic hypothermia, administer a high bolus of epinephrine, or attempt a synchronized cardioversion. What is your answer here? What is your answer here, guys? Administer a high dose bolus of epinephrine. What can you tell me? What actually is that? This was given in the question. Yeah, this is actually given in the question. But what is high dose bolus of epinephrine? Can you guys tell me? Okay, first let's talk because these things are very important. Yes, Dr. Lumayo. Okay. Okay. What is the dose of epinephrine? What's the dose for epinephrine? Okay, a dose of epinephrine or adrenaline. How do you administer? Can anyone tell me? Okay, that is actually, yeah. Okay, okay. 1:10,000. But what is the dose? This is actually weight based. Okay, one is saying E, attempt a synchronized cardioversion, because I can see A, someone saying D, and someone is saying E. Okay, A, D, and E. I can see the answers. Okay, you guys figure it out and tell me. Okay, by the end of the session, please tell me what is the dose for epinephrine. It's very important to know. Okay, yeah. Okay, sorry, I saw the answers. Sorry. Okay, so this is first of all diagnose what is exactly, yeah, 0.1 per kg. Hmm. So actually this depends. Okay, so if they ask to you in the ml, okay, if they ask you in the ml, it is actually on the basis of the weight. Okay, so if it's less than 7.5 kg, then you just mostly go with the zero point 0.3 ml. Okay, 7.5 to 20 mg, you can go with 0.3 to 0.5 ml, or more than 15 kg, or in the adults 0.5 ml. So 0.5 ml is actually your maximum dose. Okay, 1 is to 10,000 or zero point 0.1 mg per kg. Yeah. Okay. So for what is the diagnosis over here? First, tell me. It is VFib, but what is actually what you can see it in VFib? Can I call it as a refractory VFib? Okay, if you give the two attempts over here, the two attempts of the defibrillation along with epinephrine you are doing, it's still not resolving. Okay, then it is a refractory VFib. Right, and for all this refractory VFib, you have to actually start administering the IV immunodoron. Okay, that is what you are supposed to start. That is what you're supposed to start over here. Right. Early defibrillation. See, now again over here, see, this is why I keep on focusing in CVS, like this cardiology, they love to ask this question. What is the next line? What is most appropriate? Right, what is next line and what is most appropriate? Right, that is how it goes. Hmm? Yeah, so what is the next line? Even if they're asking this, the next line would always and always remain defib. Please never be confused in these things. Okay, please never be confused. Okay, the next line would always be defib. Okay, defibrillation. You have to try to recover the rhythm. Right? That is what if they ask you for the most appropriate. Over here, you have to start with any anti-arrhythmic drug. Over here, it is an immunotron. So quite recently, they have started asking some other anti-arrhythmics as well, which is actually flecainamide, butylide. Okay. Okay, but most of the names I'll give you the immunotron, but there's nothing wrong in remembering these names as well. Right? If it is a refractory VFib, okay, only two drugs. One is epinephrine and another one is immunotron. Okay, one is epinephrine and another one is immunotron. Always remember this. I'll show you, before we come to the VFib, I want to talk to you guys about the acute cardiac arrest algorithm. This is from ACLS. Okay, right. I think there is some little bit difference between the SELS, which is actually by AH. This is by AH, American Heart Association, right? And I think the resuscitation of Australia. Most of the times the guidelines and everything, they're like same. They're a bit parallel to each other. The reason why I would advise you guys to go with the AHA guidelines, because it is actually, firstly, it is very widely available, right? And second is also it is very easy to grasp, right? Okay, so now if I remove all these things, I just tell you that you're just seeing the patient. Patient is going into the cardiac arrest. In the ECG, you see the VFib and everything. Next line, what? Always on this. First thing, what you'll be doing is start CPR. And never forget, start high quality compressions, which is CPR. Then you check for the rhythm, whether it's a shockable or non-shockable rhythm. What are the shockable rhythms? VF and pulseless VT, atrial fibrillation and pulseless VT. Others is an asystole or PEA, which is actually pulseless electrical activity. So all the other electrical rhythms, all the other rhythms, which is except VFib and pulseless VT, those would be in the PEA or an asystole. So these are the non-shockable rhythms. So sometimes they actually give you the CPR is delivered. What is the next thing D2 will give? CPR is delivered, epinephrine is given. What is the next thing you will do? Okay, so sometimes, because I've told you, if the patient is unstable, then you go with the shock, right? But that is only for the patient which is for the shockable rhythms. Okay, if they're giving to you in the ECG, right? If they're giving to you in the ECG, like say for example, they're giving it to you a pattern like a narrow tachycardia, right? Like this narrow complex tachycardia they're giving to you, right? And they're saying to you that the patient is unstable, the patient is in cardiac arrest. Okay, wait a minute, what happened? Yeah, you can see the screen. No? I think I lost my connection for a while. Yeah, it's better now. Okay, so you have to check whether the rhythm is shockable or non-shockable, right? So sometimes they'll give you these some neurocomplex tachycardia, right, in the ECG, right? But in the conditions when they say the pulses is not recordable, the BP is not recordable, the patient has fainted out, the patient is unconscious. That means the patient is unconscious. Right? Patient is in cardiac arrest, right? So over here you're not supposed to actually deliver the shock. So over here only one drug, which is epinephrine. Keep delivering epinephrine, CPR, epinephrine, CPR. Okay, epinephrine you repeat every 3 to 5 minutes. This is for the non-shockable rhythm part. For the shockable rhythm part, okay, you give the CPR, continue CPR, right? Yeah, I think you guys will be knowing that every 2 minutes you are supposed to check for the pulse as well, right? You check whether the rhythm is shockable or non-shockable. If yes, shockable it is, then okay, you have to just keep checking for the rhythm as well, huh? So deliver the shock, give the epinephrine, okay, and after these this thing, you are also now supposed to start with the immunodrawn as well, immunodrawn and lidocaine as well, right? So this is what it has happened. This is exactly what has happened in this question. Can you see? They saw the rhythm first. They deliver the shock. Keep giving the CPR. Again, they check for the rhythm. They deliver the shock. Everything, right? Again, this too, they happened in the ambulance, checking for the rhythm twice. And for the third time, they checked the rhythm. That was there. They were there in the hospital, and they still saw that the rhythm is ventricular fibrillation, right? So what was the first thing? Now you're supposed to give the immunodrawn. So after the two shocks has been delivered, okay, and then for the third time when you're going to check for the rhythm, then over here administer immunodrawn, right? So what now it is supposed to be actually, now you should be alternating the immunodrawn and shock, immunodrawn and shock. So after you deliver the immunodrawn, okay, you give the CPR for 2 minutes, and after 2 minutes you again assess for the rhythm. If the rhythm is still VFib or pulseless VT, then now you deliver the shock. Okay, then for the next time again the VFib or PVT is persisting, then you go with immunodrawn. So keep alternating immunodrawn, shock, immunodrawn, shock, right? In that way you are supposed to do, right? And epinephrine, don't forget epinephrine. You are supposed to repeat it 3 to 5 minutes. Okay, this is a little bit complicated, but this is something that you keep in mind, right? So when we actually are doing the 5 rescue CPR, so you actually have a T. One is on the medication, one is on the compressions, one is on the airway. Okay, and one sometimes you also have the recorder. So over there in the actual scenario, it actually becomes very easy, right? Because someone is already taking the note of what a medication is given at what time, right? So please keep these things in mind. Okay, VFib, ventricular fibrillation, I already told you. It is a wide complex tachycardia, okay, irregular RR intervals and no appreciable P wave. So it is nothing but it is actually a ventricular fibrillation, right? So patient needs immediate defibrillation, nothing else. VFib, immediate defibrillation, okay? Do not think of anything else other than this, okay? This was an ACLS algorithm, okay? Let's go to question number 5. Yeah, as always, I take a lot of time in explaining things, and I take more than the stipulated time. No worries. Okay, this is again a very important question, and if you guys have not attended my lecture, then this is going to benefit you a lot. If you already have, then it would be a quick revision for you. A 52-year-old male presented to your clinic and concerned about the prostate cancer, as his father was diagnosed with the prostate cancer at the age of 65. On examination, the tumor can be felt. Okay, if instead of the tumor, they can also give you a mass can be felt by the digital rectal examination on both the sides of the prostate. Serum prostate specific antigen level is 10. Transrectal rectal ultrasound guided biopsy was performed, which shows the adenocarcinoma of the Gleason's core 4. What is the most appropriate management? So before we go to the management, I want you guys to grade this tumor. What we do it is a TNM staging. So grade this tumor for me, please. Yes. Before you guys go to the answer, please stage viewers. Do not really go with the answer. Okay, it's very good if you going to know the answer, but what is the staging? Someone said 4. Okay, what is the staging here? What is the staging here, guys? Stage 1B. Why 1B? Because it's affecting both the sides of the prostate. Yeah, yeah. T3. We need to go with the staging first. Okay, I'll show you the staging first, and then we'll move forward. Okay, this is your T and M staging. Okay, there is nothing as T1B actually. Okay, so what happens is, yeah, that is actually T2. T1 is nothing, it's actually an incidental finding. Okay, so T1, always remember, it is not detected in DRE. Okay, it cannot even be seen in the imaging study. It is just incidentally it can be detected. So while you're doing, say for example, the patient might have an intestinal obstruction. Okay, you're doing the exploratory laparotomy, and at the same time you might also notice that the prostate is a little bit enlarged. So it's an incidental finding, right? You're doing some colorectal surgery, and at that time you're finding this. It's an incidental finding. Okay, if it is C. Remember this key. If you can palpate it in the DRE, then directly start from T2, right? Now from the T2, what is supposed to be T2 A, B, and C? Please remember this: T2 A, B, and C. So if it is half or less than one half, one side of the lobe, right? It's a T2A. What is T2B? More than one half of the lobe. What is T2C? Tumor is positive in both the lobes, both prostate lobes. Okay, T3A and B again. So T3 is outside the prostate on one of the both the sides. That would be spreading to the epididymis or nearby testicles or anything. T3B is spread to the seminal vesicles, and T4 means widespread obstruction. So nearby organs, bladder, walls, pelvis, all of these things it will be spread to over there, right? This is your quick checkup for the classification. So now this I've taken from the Cancer Council of Australia, right? But see, this is what you're supposed to remember. Only these 4 points. So till T2A, what you're supposed to do till T2A, just active surveillance. Just active surveillance. If it is T2B or T2C, okay, if it's a T2B or T2C, it is a radical prostatectomy. If it is T3A, okay, till T3B actually, what I mean by that is, then you go with EBR, which is external beam radiotherapy. And then from T4, okay, then from T4, you have to actually go with the androgen deprivation therapy. Androgen deprivation therapy. So androgen deprivation therapy, you actually can do it by either by medically or by surgically. So medically, you actually give the alpha reductase inhibitors, all these drugs, which is flutamide, and or you can do by surgically. So surgically is just oophorectomy, okay, just surgical management. You just remove the testes as well, okay, because you're actually androgen, you're depriving them of the androgen, okay. So if the androgens would not be there in the body, what would happen? There won't be the proper growth of the prostate. Prostate is dependent on the testosterone for its growth, right? Okay, so please remember, try to remember this thing, okay. So let's first of all come to what do you mean by active surveillance. First, let's come to that. They are very specifically given to you the recommendations in the Cancer Australia guidelines. Okay. So when are you supposed to do the active surveillance? Okay, when you're supposed to do the active surveillance, either of these three, which is the PSA is less than or equal to 10. Clinical staging is T1 to T2A. T1 to T2A. Okay, and the Gleason score is less than 3 plus 4, that is actually 7, and the pattern form component is actually less than 10% after the pathological review. Okay, here you are supposed to go till what? You're supposed to go with the active surveillance. Please remember these things, guys. Okay, please remember. Okay, and also remember, all three of this should be positive, not just one. All three of this should be positive. The PSA, okay, what are these three things? Please try to cram it up if you can't remember. PSA should be less than or equal to 10. The staging should be till T2A. That is what I've written over here as well, no? In the active surveillance, till T2A, okay? And the Gleason score, okay? Gleason score is actually in the recent recalls, I think they've started giving you the Gleason score as well. So Gleason score, actually you do it in the A plus B format. Okay. So actually, what you're doing, the microscopical examination of the tissue sample. Okay, what you take it from the prostate when you're doing the TRUS. Okay, ultrasound guided biopsy. So when you send it for the biopsy, what you can see, this is the biopsy finding. So A is A plus B. So this TNM staging, sorry, the Gleason stage score, it goes from 1, 2, 3, 4, and 5. Okay, so as you go down in the descending order, the cells get more malignant. So 5 is most malignant, okay, and 1 is most benign, the cells, right? So what they check, what is the histopathologist going to see? Like in that specific biopsy sample, what is the majority of the types of the cells that you can see over there? Okay, and that would be the A. And what is the second most majority that you can see it in the sample? That would be B. Okay, so when I say 3 plus 4, okay, see 3 is actually borderline. Okay, from the 4 it is malignant. So what do you mean by 3 plus 4? Then most of the cell samples, what does the pathologist mean by 3 plus 4? Most of the cells in this given specimen, okay, that is of grade 3, but some of them are also of the grade 4. Some of them are also of the grade 4. Now remember, this is biology. Okay, 3 plus 4 is not equivalent to 4 plus 3. Okay, because when I say 4 plus 3, it is actually now more towards malignant. So most of the cells over here in your sample is of grade 4. That means it's malignant. Okay, you have to go with the radical prostatectomy now. Right, so that is what they've given to you, the Gleason score less than or equal to 3 plus 4. So really don't just go with the score, right? So the score of 7 is actually very tricky to know. The score of 7 is actually very tricky. So what do you mean by 7? Is it 3 plus 4 or 4 plus 3? So when they give you the score of 7, mostly they'll be giving to you in this format. It's 3 plus 4. If it's a 3 plus 4, well and good, just go with the active surveillance. But if it's 4 plus 3, then you have to go with the radical prostatectomy. I hope I'm making sense to you all guys. So if all three of these things, not just one, all three of these things is present in your patient, right? Then you're supposed to go with the active surveillance. Now, what do you do in the active surveillance? In the active surveillance, what you do is the prostate sample PSA levels, okay, prostate specific antigen, you do it 3 monthly, and DRE you do it 6 monthly, right? And you repeat the biopsy in 6 to 12 months. This is what you're actually doing the active surveillance, okay? So now, knowing all these concepts now let's come to our question. Hmm? Now let's come to our question, okay? So here what they are saying to you is the prostate is both the sides, is actually both sides. So someone who says actually saying T2B, actually it is T2C. It doesn't change your answer, okay, but it is actually T2C, right? And the node is not given to you actually, and the Gleason score is less. Okay, so see, now do you understand? Okay, so you might be confused between 1 and 3. Should I be going with active surveillance or not? Here the PSA is also less than 10, less than or equal to 10, the PSA is 10, and the Gleason score is also less than 7. The Gleason score is 4. Okay, then what is not followed here? Okay, I told you the 3 factors. So this is a direct recall, guys. Okay, so if you don't know this concepts well, this is very easy that you'll be going with the what? With the continuous surveillance. Hmm? And thus they just can push it out, okay, but till what, till T2A you are supposed to go with active surveillance, no? So in this question they just give you that they are supposed to, they know they're feeling the tumor, okay, in just one lobe of the prostate, then it will be T2, and now your answer would be active surveillance. Now your answer would be option 3, okay, and not option 4, right? So this is why I told you that all 3 criteria that I just told you, all 3 must be followed, right? So actually PSA less than or equal to 10 and Gleason score less than 7. This is actually indicative for what? Benign. So here just you're supposed to do is you're just supposed to do the active surveillance. The one thing which is not fitting over here is the staging. The staging is actually T2C. So here you're supposed to do the radical prostatectomy. I hope these things are clear to you. Okay, I hope these concepts are clear to you. Okay, I see a lot of students being confused and questions for the prostate. But this is like very important questions, okay, which they can ask. Let's come to the next question. A 58-year-old man with a history of CKD stage 3 type 2 diabetes mellitus and body mass index of 33, obese, right? Presents with the acute onset of the severe pain, redness, and the swelling in the first metatarsophalangeal joint. Lab findings reveal serum uric acid of 6.2, WBC count 12,500, ESR 40, and joint aspiration negatively by refrigerant needle-shaped crystals. Okay, under polarized light microscopy, what is the most appropriate initial management for this patient in the acute flare of gout? Okay, I can see the answers rolling. Somebody is saying E. Let me just go through the options. Allopurinol at the low dose, febuxostat initiated at the dose of 40 mg per day, colchicine at the 1.2 mg followed by 0.6 mg 1 hour later, NSAIDs, which is actually indomethacin. Okay, I wanted to write the indomethacin, and intra-articular corticosteroid injection into the affected joint. What is your answer here? This is a little bit tricky. Huh? This is not your regular gout questions that you actually see. Somebody is saying C. Okay, one is saying E. Okay. Okay, so I can see C. So half of the people are saying C, and half of them are, you guys are saying E. Dr. Sani is saying C. Okay. Mm-hmm. Okay, so first tell me, regardless of this question, what is your first line treatment for gout? What is your first line treatment for gout? Someone is saying D. Okay, what is your first line treatment for gout? Please tell me. NSAID, yeah. What in NSAID? Indomethacin. Please try to have an habit of speaking indomethacin, not anything else. Okay, indomethacin 50 mg TDS. Okay, indomethacin 50 mg TDS. Just a minute, I'll just put it in the form. This is what you give in your first line, right? Okay, now see, along with this, okay, this is for your acute attack. Okay, for your acute attack. Now if your patient is having CKD, as you can see it in the patient with this, cannot tolerate NSAIDs. Okay, they cannot tolerate NSAIDs. Okay, again, so many people are saying E. Okay, so over here you are supposed to go with colchicine. Over here you're supposed to go with colchicine, right? And if you don't see the resolution of the symptoms, then you can go with the intra-articular steroids. right? Now there is so many different kind of literature available for the allopurinol, right? But according to the very recent article of the RSCGP, there's two scenarios. Okay, allopurinol is actually a urate lowering therapy, right? Contact, yeah, sorry, that's okay. First, tell me, okay, for this question I want to ask, right? What is the target uric acid that we achieve for? What is the target uric acid in the patient for gout? What is your target uric acid? This is also one of the recalls. The uric acid over here is 6.2. What is your target uric acid? Because this is how you will monitor your therapy, no? Whether the drugs which you're giving is working or not. There's two management. One is the management for the acute onset of the gout. One is the management of the acute on chronic gout. And third is the chronic gout. Okay, and the management is different everywhere, right? So what is actually the target uric acid that you actually aim for? There is actually 0.36 kmg per dm, right? And if the patient is of the CKD, then your target falls down to zero point 0.3. Keep that in mind, okay? So as far as the allopurinol is concerned, okay, now the RSCGP article is saying, have I put that pictures of the article over here or not? Yeah, see. So here they're actually, see, this will actually solve you. Treatment of the acute flares should begin as soon as possible. NSAID, which is indomethacin or colchicine, are considered the first line agents. Oral corticosteroids, okay, or even for the intrathecal corticosteroid, which so many people were saying, the option E, is reserved for those who cannot tolerate, who have contraindications to the first line agents as well. Okay, so for the colchicine, they can have the allergy to the colchicine. So, say for example, here they give you the allergy to the colchicine as well. Then you can go with the corticosteroids, right? There are also the patients. Okay, the patient is presenting to you. Say for example, they are not able to tolerate the oral drugs. The patient is already debilitated, or the patient is already on nasogastric tube feeding. Like maybe the patient having certain like symptoms of stroke or anything, right? So patient is not able to tolerate the oral medications, right? There definitely you can go with the corticosteroids. Is this thing clear to you? When you with NSAID, which is actually indomethacin, when you go with the colchicine, and when you go with the steroids, okay, as your first line, these three are your first line medications for the acute flare of gout. Okay, but all three of them are specific indications when you're supposed to use it, right? So colchis 1.2 immediately is followed by the 0.676 hours date. Okay, and then so this dose. Okay, if you remember the dose, it's well and good. If you don't, then that also is fine. Sometimes they are not very picky for the dose, right? Okay, so now regarding the allopurinol, hmm, allopurinol, I'll tell you two things. Okay, this can be started in the acute attack of, can be started in the acute flare. Okay, and say for example, if this is an acute on chronic gout, okay, the patient is already chronic gout. Okay, colchicine is also contraindicated in the CKD. No, actually, you give the colchicine dose moderation is there. There's actually a dose moderation that you can see it over here. I think. I'll just quickly look at it. What is it written over there? Yeah, yeah. See, for the CKD, what you're saying is, okay, what you give it over here is actually for the colchicine. Okay, as far as it goes, at colchicine you have to actually give it in the low dose, right? So it was there in the recall, but actually you can give the colchicine in the lower doses, right? You can actually give the colchicine in the lower doses, because in that way, if you see in the CKD, you cannot even give the steroids. Steroids is also contraindicated over there, right? So steroids we talk for the full dose, because over here, if you want to settle for the acute flare of the episode, steroid is not contraindicated, but it would be denigrating for the patient to give the steroid as well for the patient with the CKD. So colchicine actually you can give it in the lower doses. Colchicine can be given very well. It can be given in the lower doses, right? And over here also, yeah, see, even lower colchicine doses are required for those with the renal impairment or receiving this. It is clearly mentioned over here, right? Can be is clearly mentioned. So colchicine lower doses can be used in the patients with the CKD. Hmm? Okay, so I was talking about the allopurinol. So if the patient is presenting with acute and chronic gout, the patient is already a known case of the gout and already on the management, which is urate lowering therapies, right? So previously it was thought that allopurinol should be stopped in the acute attack. No, it should not be stopped. Okay, it should not be stopped, and you can also consider them it starting it in the acute flare as well. Okay, please try to remember these things. Okay, this is there for the allopurinol. But if they're asking you the first line management, the first line management for the CKD patient, undoubtedly it would be colchicine. Okay, colchicine effect for the acute management, but must be dose adjusted. They have mentioned over here it should be dose adjusted in the CKD to avoid the toxicity. Actually, dose adjustment should be there for all the drugs. No, when you talk about the CKD, can you repeat when to start steroids? TI. Yeah, steroids over here is actually, see, colchicine, they can be a specific allergy. So first of all, in contraindications to the NSAIDs, we know gastric upset, gastric ulcers is there, peptic ulcer disease is there, or CKD. With these patients, you cannot give NSAIDs, or NSAID allergy can also be there. Another one is the colchicine. Allergy, specific allergies to the colchicine is that receptors, they have the history for the colchicine allergy. Or if the patient cannot, because both of these drugs are oral drugs, so if the patient cannot tolerate the oral drugs, so in this indications you are supposed to give the steroids. In this indications you are supposed to give the steroids. I hope that is clear to you. So over here your answer would be colchicine. Your answer would be colchicine. Hope that makes sense to you. I know this was a difficult question, okay, but I hope it also solves a lot of your doubts as well. Okay, I see a few questions on these things as well. Okay, not very commonly asked. 35-year-old male presents to the emergency department with a stabbing injury to the right side of his back at the T6 level. On examination, he has weakness in the right leg and loss of sensation to the pain and temperature in the left leg below the injury. Additionally, he demonstrates a right-sided loss of the proprioception and vibration sense below the lesion. His deep tender reflexes are brisk in the right lower limb. What is your answer over here? Should be syringomyelia, should be Brown-Sequard syndrome, should it be multiple sclerosis, subacute combined degeneration, and poliomyelitis? Fairly easy question, no? Fairly easy question. Yeah. One more question, similar question, I'd like to give it to you here. A 50-year-old male with a history of untreated syphilis. Untreated syphilis. This is actually your key here, if you guys know about it. Yeah. Very good, everyone. Very good, everyone. Its answer is Brown-Sequard. Let's do one similar question, which I've kept it over here. With a progressive weakness, loss of proprioception, and difficulty walking. So on examination, he demonstrates a high stepping gait, positive rhombic sign, and absent deep tendon reflexes. He also has diminished sensation to the vibration and fine to the lower limbs. Now, what is the diagnosis here? What is the diagnosis here now? Okay, one is saying A, Dapes dorsalis. Anyone else? Yeah, so answer here is Dapes dorsalis. Okay, let's quickly look at all these things first. Okay, so I've kept it to you. See, what are the tracks involved? So there are certain tracks which you're supposed to know of right as of now. Okay, there are certain tracks that you're supposed to know. Okay, three tracks is there. One is dorsum column, one is corticospinal, another is a descending hypothalamic. Yeah, so dorsum column tract, corticospinal tract, and descending hypothalamics. Okay, which is actually your, in other words, the spinothalamic tract. Right. So you guys know the functions of all this tract. Dorsum column tract, okay, the dorsum column tract is responsible for the proprioception, vibration, pressure, fine vibrations and all, right? Fine touch below the lesion, right? Corticospinal, that is for the paresis, everyone will be knowing this thing, okay? Spinothalamic tract, that is for the pain, yeah? It's got loss for the pain, right? So please remember these three tracks: corticospinal tract, dorsum column tract, and spinothalamic tract, right? So now let's do this, okay? This will make it very easy for you, okay? So if all these three tracks, all the three tracks which I just told you, all three tracks, dorsal column, spinothalamic, and corticospinal tracts, all three tracks are involved, right? So what they'll give it to you in the history, they have the history for the loss of vibration, okay, fine touch, okay, they have hemiparesis on the opposite side of the body, contralateral, and they have the loss of pain sensation. Please remember, please remember in this Brown-Sequard, the dorsum column is ipsilateral, corticospinal is ipsilateral. Actually, the spinothalamic tract is the only one which is actually crossing the midline. Yeah, after the section. For this, you should be knowing the neuroanatomy, right? So this would be there, like the same side and opposite side. Don't forget these things, okay? So if all these three tracks are involved, then it is actually what? It is actually your Brown-Sequard syndrome. So Brown-Sequard syndrome. Now they tell you this, okay, now keep, just adding and subtracting. Okay, so DC subtracted, okay, it's just spinothalamic tract and the corticospinal tract, then it would be ASA occlusion, anterior spinal artery occlusion. Okay, now subtract the STT. So dorsum column tract and the corticospinal tract, those involvement is that is actually what? Some acute combined degeneration of spinal cord because of the vitamin B12 deficiency, right? Now it is only dorsum column tract. So what they give it to you in the question: loss of proprioception, fine touch, vibration. That is all they give you, and that is also on the bilateral. This is on both the sides, right? Then it would be what? Tabes dorsalis. Here, very specifically, they'll give you what? Erigal Robertson pupil. Erigal Robertson, sorry, but can you go a little slow here? Yeah, sure, I can. Okay. And then you can also, there is also rhombic sign. costal, that they will give it to you, and very clearly, always in the question, TEPS dorsalis, they will always give you the history of syphilis, untreated syphilis. So if you guys will be knowing, there is primary, secondary, and tertiary syphilis. Okay, so in the primary syphilis, you have ulcers. You have ulcers. In the secondary and the tertiary syphilis, so in the secondary syphilis, what now you have just the constitutional symptoms, but this ulcers would be resolved, right? And in tertiary syphilis, now it starts to affect your cardiovascular system. There can be the gummas over there. There can be stenosis and everything, which is causing the valve degeneration and all. And it can also cause what Taves dorsalis for the neurology. That is tertiary syphilis. Okay. And if it is just a spinothalamic tract, I'll repeat all these things. Okay, guys, don't worry. I'll repeat this. And if it is just a spinothalamic tract, okay, then it is your syringomyelia. Then it is what? It is actually a syringomyelia. So they will give it to you in the question, right? The subthalamic tract, that there is a loss of the contralateral or the bilateral, there is a loss of pain. Okay, for the spinolateral, loss of pain sensation. Okay, so that is already syringomyelia. Now there is one term which they use it in the questions in AMC, which is actually syrinx. Okay, SYRINX, syrinx. So along with the syringomyelia, you also have the history of the facial palsy. Then it is syrinx. Okay, so guys, what I was telling about you on this is there is 3 tracks which is available. 3 tracks which you have to know. I know neuroanatomy is actually very difficult to know, right? Neuroanatomy is actually very difficult, right? But for the sake of AMC, if you just remember these 3 tracks, I think that will be more than enough, right? What are these tracks? Dorsum column tract, corticospinal tract, spinothalamic tract. Okay, what is a dorsum column tract? Dorsum column tract is responsible for your proprioception, for your vibration, for your pressure, for your fine touch, right? What is corticospinal tract? Corticospinal tract, I think it's easiest. Everyone will be knowing. That is for what? For the movements. Okay, so loss of the corticospinal tract would be causing the hemiparesis, right? That is below the lesion. And spinothalamic tract, that is responsible for the pain sensation, right? So what I said is, so these 3 tracks, if all three tracks is involved, it is a Brown-Sequard syndrome. Okay? So let's come to this question first. Here the answer was a Brown-Sequard syndrome. Okay, so first let's look at the symptoms over here. What are the symptoms that the patient is giving to us, right? He has a weakness in the right leg. Okay, weakness in the right leg, that means it is an involvement of what? Corticospinal tract, right? And there is also ipsilateral. Loss of sensation to the pain and temperature in the left leg, right? There is actually pain sensation, spinothalamic tract. Okay, there is on the left side, so contralateral side, right? And loss of vibration, proprioception, and the vibration. Okay, proprioception and vibration. That is what? Dorsum column tract. Okay, and that is say it is in the what side? Right side. So that is actually also your ipsilateral. Okay, the injury is on the left, on the right side. Okay, so all 3 tracks are getting involved. That means it is your Brown-Sequard syndrome here. Okay, which you guys very correctly diagnosed, right? Now you have to just do the mix and match. Okay, so if it is all 3 Brown-Sequard, okay, just spinothalamic and the corticospinal, anterior spinal artery syndrome, right? Just dorsum column and the corticospinal, subacute combined degeneration of spinal cord, B12 deficiency. Only dorsum columnar tract, it is Taves dorsalis. Only spinothalamic tract, SNS. Okay, then it is a syringomyelia. I hope that is clear to you. So whatever symptoms they are giving to you in the questions, on that basis you will identify which tract is involved here, and whatever tract is involved, on that basis you will what? You will diagnose the patient, right? So here it's really good they've given you the history of the untreated syphilis, right? What if not? If it's not given to you, then just high stepping gait, positive Romberg sign, okay, and diminished sensation of the vibration and the fine touch in the lower limbs. This is actually the function of the dorsum column tract. Okay, nothing else is there. Okay, nothing else is there. Loss of operation difficulty, walking is that. There is no history for the paralysis yet. Just progressive weakness there, what they are telling. Okay, then it is actually your Taves dorsalis. I hope this is clear to you now. Is this thing clear to you now? Okay, let's quickly go to this question. A 52-year-old male with a history of the alcoholic cirrhosis come to the ED with hematemesis and melena, hemodynamically unstable with a blood pressure of the 85 by 60. Heart rate of 180 minutes. Cool extremities, pallor and ascites. Okay, hemoglobin is less, 6.9. Platelet is also reducing. INR is 1.8 increase. Creatinine is mildly increased, and blood urea nitrogen is 28. Right? Management so far, they've given you the IV cannulas, they've given you the crystalloids, they've given you the cross matches already sent for the PRBCs. What is the next best step in management? Give me the answer, please. Administer a PPI infusion and perform endoscopy within 12 hours. Start vasoactive drugs, terlipressin, and initiate the antibiotic prophylaxis. Perform immediate endoscopic variceal ligation. transfuse the blood to normalize hemoglobin more than 10, or refer for tips, transjugular, intrahepatic, portosystemic shunt. What is your answer here, please, guys? Okay, please, again, I'm saying this always be very, okay, so in this we'll try to answer what is the next step, what is the most appropriate. Both answers you will have to give me. Okay, here in this question is next step. So let's start with the next step. What is the best next step in the management of this patient? What is the diagnosis first of all? First, please tell me what is the diagnosis. Okay, people are saying C. Okay, first tell me the diagnosis. What are your diagnoses over here? What sort of hematomesis it is? Esophageal varices. Yes, it actually is a variceal bleed. Yeah, it is actually a variceal bleed, right? So what is your next best step in management over here? They've given you already the fluids and everything. Okay. See, always see. This is what I've noticed actually. Sometimes in the quest of reaching to the correct drug. Okay. Sometimes we are so occupied with the drug that what drug should I be going with? Okay. We normally forget the DRS ABCD approach. DRS ABCD approach we forget, right? So what if I remove this part? Okay, then what would be the next step in the management? The next step in the management actually in this patient would be administering fluids. Okay, insert the IV cannula and give IV crystalloid resuscitation. That is actually so. Never and never forget in the cases of emergency, never forget the DRS ABCD approach. Okay, so first you should be what you be doing. You should be giving them the fluids, but this is already given to you in the question. They've already given you the fluids. So now you can go with the specific drugs. Okay, okay. Someone is saying D. Transfuse the blood to normalize hemoglobin to the 10. Doctor, do you know how long does it take, even if you transfuse the blood, how long does it take to stabilize the hemoglobin? Hmm? Okay, and there is one actually a thumb rule. There is one central dogma, you can say it, of blood transfusion. Okay, never there is no point in giving the blood transfusion until and unless you have identified and repaired the site of bleeding. Okay, but this is like the tap mechanism. You're just giving the blood and the blood will be getting lost. So what is the point of giving the blood transfusion? Right? There's no point of giving the blood transfusion here. Right? So that you just remove it out. Okay. Someone is saying C. C is a little bit of a legible answer. I can take that. Okay. Okay. And one was saying totally pressing. Any other answer? Any other prompting? Let's guys, please be more active, and we have more 6 questions to go, and then I also need to give the tips. Somebody is saying administer PPI infusion and perform endoscopy within 12 hours. Can you afford that? Can you afford to waste 12 hours when you can already see there's the patient is going into hypovolemic shock? Can you see it over here? He has cool extremities, pallor, ascites, everything. The BP is also falling, right? What good would PPI do, right? Endoscopy is right, but if you do the urgent endoscopy, then it's a different thing. But still, endoscopy is therapeutic. It is not. Endoscopy is diagnostic. It is not therapeutic, right? Okay, let me come to the flow chart. Okay, which is actually this is an excellent flow chart. This is a theory that you're going to go to. I'll not go through it, but this is excellent flow chart for the management of acute variceal bleeding, which I got it from the up to date. So, what is the initial management? Initial management. Okay, this will answer all your questions. Giving blood mean massive transfusions as well. Yes, Dr. Jishan, I'm coming to it. Okay, first thing I told you. First thing, never forget the DRS ABCD approach. So, in all the patients with the shock in the all emergency conditions, you see shock, you see hypotension. First thing what you will be giving would be hemodynamic stabilization. I know this is a very basic point, okay, but people do a lot of mistakes there, and AMC want to test you this only, right? So first, give them fluids. Second is when it comes to the variceal bleeding, we do something which is known as a restrictive transfusion strategy. What is restrictive transfusion strategy? Right, hemoglobin thresholds. Actually, we give them the threshold of the 7 gram per deciliter. Okay, so if the hemoglobin is less than 7, then we can consider giving the blood transfusion. Then we can consider giving the blood transfusion. Now, don't come and tell me that in the question the hemoglobin is 6.9 something. No, okay, then why are we not going with the blood transfusion? Right? See, this is what are they giving to you in the answer? If you look at it, actually, all of these options which you can see it over here, all of these things we'll be doing. But can we do all of these things simultaneously? That is why then there will be no point of the questions. So they're saying that next best step in the answer they're asking. Obviously, we'll be transfusing the blood. The hemoglobin is less. the hemoglobin is less than 8, according to the Australian guidelines, if the hemoglobin is less than 8, then you go with the blood transfusion. So obviously we'll be going with the blood transfusion over here. That is not the first thing we will do. Firstly, we will identify the source of bleeding, we would correct that, and then we would give them the blood transfusion, right? Right? That you should be doing, and antibiotic prophylaxis for the patients with the cirrhosis, they should be doing, right? So all these three things we are doing, okay, but at the same time you are actually initiating the vasoactive agent, okay, which is that terlipressin, octreotide, vasopressin, or somatostatin. Mostly in the exam they give you terlipressin or octreotide, okay. Now you're initiating this, now you can go with the upper endoscopy within 12 hours. Okay, so someone is answering option A. That is not wrong. That is not wrong, but you have to do something, no, to stop the bleeding, as I told you. Okay, you identify the site of bleeding and you stop the bleeding. That is something you have to do. So next thing what you be doing is you do the upper endoscopy, that you do it in the within the 12 hours. So now your source is confirmed or suspected. So the source is confirmed. Okay, you're going to the endoscopy. This is actually and that endoscopy would be therapeutic as well as diagnostic. You're doing the endoscopy within the 12 hours, and then you identify the source of bleeding. The third thing what you'd be doing would be doing the variceal ligation. You'd be ligating that part, whatever bleeding is that, you'd be ligating that part. Okay, but if you're not able to confirm the source, then you just manage on the conservative basis. You have to stabilize the BP of the patient following the TRS EPCD protocol, right? So you do the endovascular variceal ligation, and the bleeding is controlled. That's well and good. If the bleeding is not controlled, there's continued bleeding with the recurrent bleeding, then what is the fourth thing? Now you go with TIPS, transjugular intrahepatic portosystemic shunt. Then you go with TIPS, right? Okay, so there is actually continued bleeding. Bleeding is not controlled with the variceal, endoscopic variceal ligation. What if the bleeding is controlled? Now again you have to see. See, this is very highly conceptual. Please be focused over here, right? So if the bleeding is controlled now, then now you have to see the whether do I have the high risk for the failure or rebleeding or not. Okay, I need to check. Okay, whether it is a high risk for the bleeding or not. Is there any place for PPI in acute management? Actually, you start with the PPI. Actually, you can. Okay, there is something that is actually a supportive role. The PPI has got a supportive role over here. Okay, it is not like H. pylori gastritis. Okay, H. pylori gastritis actually it is the specific management for the H. pylori, right? So high dose PPI, yeah, you can start it. You can definitely start it, but that is actually for the component to manage for the alcoholic cirrhosis, right? So high PPI you can give it over here, but that is not actually the main. It is not in the mainstay management algorithm for the variceal bleeding. Okay. So high risk for the failure means what? So already the patient would be, patient has a history of variceal bleeding, right? And you've done the variceal ligation, but you know how profuse it is. So sometimes the perforation is so huge, you just try to ligate it anyhow, just to stop the bleeding. But this is the surgical mind. So by the surgeon, he knows that this will rebleed again. So if that is the case, then you can actually go with the early TIPS, where you can actually give the TIPS over here. Even after doing the variceal ligation, you can go with the TIPS. That you can do it within 72 hours. Okay, within 72 hours you'll be doing. But for the TIPS, okay, for the TIPS, this is the contraindication of the TIPS which you are supposed to remember. So should you be going with the TIPS or not? TR is tricuspid regurgitation, pulmonary hypertension, heart failure, portosystemic encephalopathy. Okay, portosystemic encephalopathy. So what you're doing over here for the TIPS, okay? So just like sometimes I think so from the any vein of the leg you are inserting it, okay? Then through the IVC or SVC, superior inferior vena cava, okay, I'm giving you the route for the TIPS. That you are going, and on that basis you are going towards the heart. Okay, they're going towards the heart, right side heart. Okay, then you are going with what? To the pulmonary valve, then you're going to the lungs, and from the lungs, okay, you're going to your systemic circulation. From the systemic circulation you go with the portal vein, okay, and then it goes to the portal vein, and then it stabilizes the pressure for the bleeding. Okay, this is actually portosystemic portal hypertension, no? So this is how you are stabilizing the hypertension. So if there is deformity with any of this, with the heart, let me get my highlighter. So if there is deformity with any of this, with your heart, with your lungs, with your portal veins, anything. So heart, it could be tricuspid regurgitation with the pulmonary hypertension, or heart failure, or portosystemic encephalopathy already. Then you cannot give TIPS. Okay, then you have to go with the surgical procedure. They were asked it once or twice this question. Okay, there was in the history they told you that the patient is a known case for the heart failure with reduced rejection fraction. Patient also has CKD. Patient also has ascites. So they gave you all this in clinical. Also they give you in the question. There is an edema of hands and legs. Okay, patient has a history of the shortness of breath. So typically they give you the history for the heart failure, that the patient is having the heart failure. Okay, TIPS was there in the option. Many people they went with the TIPS actually, but TIPS is contraindicated in the heart failure. So there you go with the surgical procedure. You can go with the shunt or not shunt. Okay, the shunt would be the distal splenorenal shunt. So just for the exam purpose, just remember there's a distal splenorenal shunt that you'll be doing, right? But if none of these contraindications is not present, then definitely you can go with the TIPS. So this is actually your detailed management for the acute variceal bleeding. So here they are asking the next line in management. So now to answer your question, the next line in management over here would be what? Would be the vasopressors, which is actually your terlipressin, opioid, anything, right? And most appropriate management over here would be either endovariceal ligation or TIPS. That would be most appropriate because that is actually stopping the bleeding, right? This is actually stopping the bleeding. So what actually in the variceal ligation, there is a massive splanchnic. I'm saying splanchnic circulation is there, no, which is circulating to the liver, to the spleen, to the pancreas. There is actually wide vasodilation of the splanchnic circulation. Splanchnic vasodilation is there. What this terlipressin octreotide do? They cause splanchnic vasoconstriction. So this would be because of this there will be reduction in the supply of the blood in all these organs and hence less bleeding. Okay, so this is why actually for this drug, this is actually a temporary arrangement that we do. So here you give the octreotide or terlipressin and then you identify the source of bleeding by endoscopy by doing it within 12 hours, and then you do either the variceal ligation. If the variceal ligation is stable, well and good, just keep it over there. If there is a risk for failure of that ligation or there is a risk of rebleeding, then you go with TIPS. Okay, but if you are not able to stabilize with the ligation, then anyways you'll be going with the TIPS. So that is your answer. Okay, I hope that is clear to you. Mm-hmm. Okay, this is actually a little bit difficult question. I think we're running a little bit out of time. Okay, I think they were already providing you the. Yeah, just let me just quickly go through it. Okay, they might not give you the PDFs for this. I don't know. Let's just quickly try to go through these things, and then we'll go to some certain tips and tricks for the examination. That also I want to cover in detail. Okay, 65-year-old male presents to the emergency department with a severe lower abdominal pain and vomiting for 2 days. History of the chronic constipation, but no previous episodes for the diverticular disease. Vitals on the admission: temperature of 38.5 degrees, pulse is 110, BP is 100 by 65, respiratory breath. Okay, WBC is raised, CRP is raised. Abdominal CT scan: there is a pericolic abscess measuring 5 centimeter diameter with the signs of inflammation, but not free air. First, let me please diagnose this case. What is your diagnosis here? Actually in the exam, you know what, this I've given to you, they directly gave you the CT scan. Even in my exam for the AMC, there were lots and lots of CT scans, X-rays and everything. Perforated appendix. Pericolic abscess. Abscess is there, pericolic abscess. There is no sign for the rupture or anything. What is your diagnosis here? Yeah, diverticulosis. Yeah, actually, which is suspending into diverticulitis. Very good. Okay, acute diverticulitis. So this is what you see it in the CT scan. Okay, this CT scan was given, and I can understand this is actually difficult. Yeah, so you had to actually look at the level of your CT scan, right? So what you can see it over here is in the intestine. So here, whenever this give you the fluid air space, it is mostly an abscess. Okay, this is pericolic abscess, and they give it to you in the question. Pericolic abscess was more than 5 centimeter, right? More than 5 centimeter, right? Measuring 5 centimeter. Okay, so there is actually in the first let's go before going to the answer. Do you guys know the answer for this, or should be doing the best step in the management? If someone can answer for the sake of asking, this is a difficult question for sure. It is bowel rest, IV antibiotics, observation, CT guided percutaneous abscess drainage, urgent laparotomy in the heart procedure, colonoscopy for confirmation for diagnosis, roller antibiotic and discharge with the outpatient follow up, drainage. Yeah, did you see the answer over there when I was scrolling through? Just kidding. Yeah, so what is the answer over here? Yeah. The answer over here is the percutaneous abscess drainage. Actually, it is fairly simple also. You can, if you want to take a guess, you can actually do it, right? See, one thing which is over here is actually, yeah, for the diverticulitis disease, the left iliac fossa, how would you identify it? As left iliac fossa, there will be a sharp pain, which is in the area of the sigmoid colon. Okay, complication, abscess, obstruction, perforation, peritonitis, anything. Okay, yeah. So there is actually, I hope I have included that over here. There is actually an Hinchi classification. Okay, Hinchi classification. There is already inflammation or anything. There is no fluid collection. Okay, there is actually one. There is an abscess which is less than 4 centimeter. So for this cases, you only manage the patient in the outpatient department, the OPD, or it can be inpatient management as well. But you start it on the antibiotics. You start the patient on the antibiotics. Okay, but if the classification is like abscess, they are saying that abscess is more than 4 centimeter. Okay, then you do the CT guided percutaneous drainage. But if the Hinchi classification is 3 or 4, okay, you don't have to remember. It is signs of peritonitis that you can see. Okay, there is rebound tenderness. Okay, over in the LIF. Okay, and physically when you're doing it, shifting tenderness and everything. When you do the CT, you can see the signs of the peritonitis, everything, right? Then you have to go with the surgical management. Directly, you have to go with the surgical management. Yes, right? So on the basis of this Hinchi classification, we are actually supposed to manage this patient. Actually supposed to manage this patient, right? And for the broad spectrum antibiotics, the antibiotics of choice over here would be gentamicin, okay, plus amox ampicillin, which is augmentin, okay, amoxiclav plus metronidazole. Clear? Therefore, diabetes. They've given you the picture, okay. Okay. So here, 56-year-old is presenting with you with the hematuria, proteinuria, and pulmonary hemorrhage. These three things, okay, and it shows P and K. Okay, necrotizing glomerulonephritis on the biopsy. What is the diagnosis of this patient first? Okay, and then we'll talk about the treatment. What is the diagnosis of this patient? Vaginers, yes. Diagnosis of here is vaginal. I think I've included one more question over here. No, sorry, one more. That is a vaginers. Yeah. First, let's compute. This is where the confusion. See, it happened with me as well. Yeah, I thought it was vaginers. See, first of all, what you need to suppose for this is right. There's actually three things. One thing is missing for it to call as vaginals. That is why I've given you the differentiating table over here. Okay, the answer it remains the same. Okay, the answer remains the same. The answer would be definitely would be cyclophosphamide corticoids. Definitely would be that, right? For the vaginous or for the microscopic polyangiitis. Please remember for the granulomatous with polyangiitis, which is actually your vaginous, right? And for the microscopic polyangiitis, what is the difference? Actually, the granuloscopic with polyangiitis, which is a newer name, which is the vaginous, it is an upper respiratory tract infection. So in that actually, yes, again the question they give the P and K, no? When the vaginous it is C and K positive, yeah, C and K positive. Okay, so in vaginous also there is an upper respiratory tract infection. So they give you the sinusitis more very frequently. They'll give you the specific sign, which is deviated nasal septum. Okay, nasal septum. And over here in the microscopic polyangiitis, it involves the lungs and the kidneys. So right. Here also it is involvement of the lungs and the kidneys, right? So pulmonary hemorrhages, okay, pulmonary hemorrhages and proteinuria would be common in both. Okay, and now you have to remember C and K and P and K. Okay, C and K and P and K. That you have to see it over here. So we are actually the question is microscopic polyangiitis, okay, or granulomatous with polyangiitis. I'm so sorry. I think there was some drainage over there. Can you see my the screen? I think in my phone it is loading. Okay, now you can. Okay, so on that basis you're supposed to do. But actually, the treatment for both is corticosteroid with cyclophosphamide and corticosteroid here with the immunosuppressive therapy. So actually, this is where it differs. So here actually you use the corticosteroids. In both you'll be using, but here you actually use with the cyclophosphamide. In here, in microscopic injuries, you use some immunosuppressive therapy, which is methotrexate as a therapy. Yeah, mesothelioma as a therapy. But in this question, yeah, you can go with the cyclophosphamide local corticosteroid. So it doesn't matter. Even if you diagnose it as the vaginous, the answer would remain same. But here actually diagnosis microscopic polyangiitis. Okay, please remember this thing. Okay, right? Okay. 75-year-old man, it presents to you with the progressive dyspnea on exertion, chest pain, episodes of hypertension over the past 6 months. Examination, crescendo, decrescendo, murmur, systolic. Okay, it is there. Heard on the right upper sternal border region to carotid. So easy, right? Okay, so echocardiography, I've just added it when the question it was not. So here, obviously, your diagnosis is what? aortic stenosis. Hmm? Now they are giving, they're not asking you to diagnose. They're going one level up. They're asking the echo, it shows severe AS. Okay, they shows the severe AS with a valve area of 0.7 centimeters square. Okay, 0.7 centimeters square. Okay, so what is an appropriate next step in the management of this patient now? Okay, so should you be starting with the beta blockers and observe, or surgical aortic valve replacement, okay, or aortic valve implantation, percutaneous balloon aortic valvuloplasty, or annual follow up with the echo? What should you be doing now? Severe AS, okay, plus there is involved with this thing. Aortic valve replacement, okay, C. Yes, very good, Dr. Dilip. TAVI, transcatheter aortic valve implantation. So that is actually true. So first, before I move into this, I want you guys to know about this thing for the area, right? So aortic valve area, what is over there, right? So actually, if it is less than 1.5 centimeters squared, so 1.5 centimeters square, okay, that is actually the valve, aortic valve area. What you can see over here, 0.7 centimeters. So it is already reduced. That means it is a severe AS. This is how you do it. No? On the basis of NMIHA grading, you can do basis on the symptomatic or non-symptomatic. So if already the grading is more than 2, then definitely you go with the surgery, right? But if it's still 2, I hope you guys know the NMIHA grading, yeah? So if it is 2, then you have to just look at the ejection fraction. If it is less than 50, then you go with the surgery. This thing you should know, right? Okay, and ejection fraction is there. So ejection fraction is reduced in the grade 3 and 4 of the aortic stenosis. 1 or 2 is mild, right? And here, actually 1, okay, 1.5 centimeters squared is the mitral valve area, and aortic valve area is 1 square centimeter, right? So how you do, if the aortic aortic valve area, it is less than 1 square centimeter. Here in the question it was 0.7 square centimeter, no? That means it is already in advanced one, so it is grade 3 or 4. So over here you are actually supposed to go with the surgical management, which is actually AV valve replacement. Okay, transaortic valve replacement you can do. It's actually alternative. It's actually an alternative, right? But actually in both you can go with the AV valve replacement, right? But here they actually give you both. So I can understand your confusion between B and C, right? So this is what I could find from the guidelines and everything, right? TAVI is actually aortic valve. It's a preferred intervention due to its less invasive nature compared to the surgical aortic valve regurgitation, right? So it actually depends on the yeah. Someone actually called it this. Very good, Dr. Apshara. It actually depends on the age, right? So the aortic valve replacement, yeah, aortic valve replacement. So now what I could find from the guidelines. So if they tell you about the aortic stenosis, right? If it is in the younger patients, then you can go with the AVR because those patients can actually 75 is young for this. The patient is, it's not young, no. That is why you don't go with the aortic valve replacement. Okay, if it's a younger patient, right, then you actually go with the aortic valve replacement. But it's an older patient who cannot actually tolerate the surgery, yeah, who can actually tolerate the surgery. Okay, there over there you go with the TAVI, which is actually your transthoracic aortic valve implantation, because this is non-invasive. It's as simple as you do just putting the stent over there, like percutaneous coronary intervention. That is what you do it. So if the patient is of elder age group and TAVI is given to you in the options, then prefer TAVI over AVR. Okay, AVR would not be wrong actually. Okay, but the TAVI would be a better one because this is in severe grade 3, actually grade 4 form of the aortic stenosis, right? But on this basis, you can actually do it. Hope that is clear to you. This is actually a detailed STEM question, but this is actually a very easy question. 45-year-old pre-menopausal presence, woman present with a 3-month history of the lump in her right breast, which she noticed during self-examination. The lump has progressively increased in size and associated with a mild discomfort, but no discharge from the nipple. Reports no significant family history of breast or ovarian cancer. Her menstrual cycles are regular. She denies regular recent weight loss or fatigue. Examination, there is 2.5 centimeter firm, non-tender, immobile mass in the upper outer quadrant of the right breast. The overlying skin, it appears normal, and there is no nipple retraction. Axillary lymphadenopathy is present on the right side with 2 palpable nodes, each approximately 1 centimeter in size. Okay, ultrasound was done, which is actually irregularly shaped lesion with a spiculated margin. Biarates 5. Core needle biopsy is performed, and histopathological examination reveals the invasive ductal carcinoma. Okay, immunohistochemistry is as shown. ER is negative, PR is negative, and HER2 new is positive. So this is actually an invasive ductal carcinoma. But here it is actually HER2 new positive. Okay, so what is actually Your next step in management. Should you be doing with the modified radical mastectomy with adjuvant therapy? Initiate the new adjuvant therapy with the HER2 negative targeted therapy, which is trastuzumab. Start hormonal therapy with the tamoxifen. Recommend the wide local excision with the sentinel lymph biopsy, or refer for the radiation therapy as the primary treatment. What is your answer here, guys? What is your answer here? Okay. See, if it's an HER2 positive, then the answer would be as simple as someone said D. No, no. Okay. It is actually you start with the HER2 negative. So new adjuvant therapy means what? New adjuvant means actually before you go with the surgery, you should start with this chemotherapy. Okay. So answer here is B. Okay. Sorry for the highlighter, but the answer here is actually B. Okay. You start with the HER2 targeted therapy, which is actually trastuzumab, and then you go with the surgery. Okay. Then you go with the surgery. Because see, what is the purpose of giving the neoadjuvant therapy? It's actually downstage the tumor. They have written over here that addition of the neoadjuvant chemotherapy can downstage the tumor and actually improve the surgical outcomes, right? So there is actually two types of chemotherapy. What is a neoadjuvant chemotherapy means, or neoadjuvant radiotherapy? Because that you actually do it before the surgery, because you want to downstage the tumor so that you can improve your surgical outcomes, right? Okay, the more surgical success can be there after that. Okay. A 68-year-old male with a history of hypertension presents with a certain episode of the left-sided weakness and difficulty speaking, which resolves within 20 minutes. Okay, the neurological examination is normal at the time of presentation. CT scan is rule of intracranial hemorrhage. Carotid duplex ultrasound shows 65% stenosis of the right internal carotid artery. On guidance, what is appropriate next step in the management? Appropriate next step in the management. What is that? What is that, guys? I hope you know it's a carotid endarterectomy within 24 hours that you're supposed to do. TIA guidelines is specifically given to you in the RSAGP. Right? And last question, 35-year-old male presents to routine health checkup. Okay, his father was, it's CRC, very common question. CRC at the age of 60. Uncle's father, brother also had a colorectal cancer at the age of 65. There is no other history of the IBD or known hereditary cancer syndromes, Lynch syndrome, anything. Okay, what is the appropriate colorectal cancer screening recommendation for this patient? First of all, stage of this tumor, please. Okay, what, not the stage, but the grade for the surveillance, for the screening, what is the type over here? Okay, what should be the answer here? Screening recommendation. Grade 1, 2, or 3. What is it? What is this patient falling in? What is your answer, guys? Begin FOB, begin colonoscopy 5 years old, starting now at the age of 35. Right now, the patient is 35 years old. Okay. His father was diagnosed at CRC at the age of 60. Moderate risk, yes, moderate risk. So begin FOBT screening at the age of 40, colonoscopy every 5 years starting now at the age of 35, or colonoscopy every 2 years starting at the age of 35 right now. FOBT annual screening from the age of 35 to begin colonoscopy every 5 years from the age of 40. What should you be going with now? Let's first of all go to this, okay? Yeah. So, category 2, yes. What is the category 1? Means one female family history. Okay, if someone said E, yeah, someone said E, that's the right answer. Finally, someone said the right answer. Okay, what is category 1? Category 1 is one first line relative. Okay, one first line relative. First line relative is only your parents, right? So it is more, but more than 60 years, right? More than equal to 60 years. So you do nothing, you just give the FOBT 2 yearly from the age of 45 to 74. And in all the three categories, you start with the low dose aspect. Yeah, I think you guys know about this. Now, category 2 is one first line, which is less than 60 years, or one first line plus one second line at any age, which is the case over here, or two first line at any age, right? So, colonoscopy, you should be starting 5 yearly. Now, remember this thing, guys, that you should be starting 10 years younger than the earliest age of diagnosis, right? Or from the 50 years, which is earlier, right? And for the category 3, okay, which is exactly more than 3 first line relatives, 2 first line plus 1 second line, which is less than 50, or 2 first line but more than 2 at the any age. So here you start 10 years younger than the earliest age of onset, or from the 40 years, or from the 40 years, right? Or from the 40 years, whichever is earlier, right? Right? First, before grade it up, okay? So what is the thing over here? Here, what you can see, it's a category 2, no? Yeah. So what is can see over here? Either you can do two things. It's a category 2. So colonoscopy you can start 5 yearly, okay, which is less than 10 years. Okay, 10 years. So here the earliest answer was at the age of 60, right? So here the age would be 50, right? From the age of 50. Either you can start from 50, either ways, right? Okay, or anyways, you can start from the age of 50. They're 10 years younger, actually 10 years younger than the earliest age of onset, which is 60 years, so that is also 50. Or anyways, you start on the 50, right? So actually, so now you have B and E option, but in the E option is age 40. Okay, so this is the type of questions you might have in the AMC, okay, in which none of the questions would be right. So what will be your closest answer now? So if you have to, if I have to select from B or E, what should I be going with now? Should I be starting at the age of 35 or should I be starting from the age of 40? Right? So if they ask you to do so, actually go select age 40, not age 35. Okay, this is actually a direct recall. Okay, and they give age 35 and age 40. They didn't give age 50. Actually, the answer should be you're supposed to start the colonoscopy every 5 years from the age of 50. Yeah, from the age of 50. Why? Because it is a category 2, right? 10 years younger than the earliest age of presentation. So here the earliest age of presentation is 60, 10 years younger to that it is 50. Okay, or anyways you start the patient at the 50. So here the answer would be colonoscopy to 5 years from the age of 50. There's not that in the option, so you go with the age 40. Okay, then you go with the age 40 over here, right? Should be age 50, yes. Okay, okay guys, so I hope that is clear to you. And here what was it for the category 3, 10 years younger than earliest age or from the 40 years. Okay, or from the 40 years. Clear? Okay guys, okay, so this was all the questions. If you guys have any doubt, please let me know. Okay, please, this is actually surveillance interval. This is a little bit difficult for the adenomas and all, not very commonly asked. Anyways, I've kept it in the options. Any guideline for the breast cancer treatment? So I'm coming to it. Okay, so first let's come to the tips and tricks for the AMC. For the breast cancer, actually, they only give for the screening. They don't ask much questions on the treatment, right? This was one question. They anyhow they asked it for this thing, for the HER2 new targeted therapy. Okay, but mostly they don't ask questions from the treatment for the management part. They ask for all the cancers. I'll talk about it. For all the cancers, the main treatment what they see it over there is main question what they ask is about the screening. Okay, main question what I ask about is the screening. Okay, so I can see some questions. Some of you guys are having the exam in the month of March. Some is having in the March. Someone is having the 8th. I think when I started, there were only few people, but now I'm having like 40 to 50 people right now. So who's got the exam in the February or March? Anyone over here who's got the exam in the Feb or March in the coming months? Me. Okay, yeah, just write me. And I'll just count you guys. 1, 2, 3, 4, 5, 6. Okay, 7. Okay, so I think about 10 people, 8, 9, 10. Okay, about 10 to 15 people. I think I can say I can just go on that way. Have got the exam in the coming month, either in the February or either in March. Okay, so I'll just give you the basic things. This you guys already will be knowing about these things. Okay, the 150 multiple choice questions is there. They give you 210 minutes. Okay, in your appointment later they would have written it's 225 minutes. So 15 minutes is for the examination procedures, right? In which they'll give you the oath. They'll give you the you won't be they want you to sign this declaration that you won't be sharing this recalls anywhere or anything. So those things are there, right? Okay, so if you talk about these things, okay, if it is a 210 minutes, so it's a total examination duration. Okay, that is actually your total examination duration. Okay, so one thing what you should keep in mind is actually you might think that this is 150 questions and 210 minutes. It's a good deal, right? You have got extra time, but that might not be the case. Okay, because it's okay like if you received the recalls and you are doing the exam lectures and everything, that's fine. Okay, but you still need to read the question very well. Okay, they'll twist it up even if the question is directly from the recalls, but still they will twist the question. Please keep that in mind. Okay, so you need to read the question really well. What are they asking? What actually are they asking? Okay, please be very conscious about it, because of time management is an issue. So try to do as many mocks as you can. Okay, mocks I think would be available for the people who already subscribed with our academy. That's very good. For those who don't, then you can also, I think there is specific courses available for just for the mock exams and for the test and everything here as well, right? They give you the plans and you can always talk with the counselors over here for what they're giving you the contact, right? So it's always a good idea to take the mocks, because time management is an issue, guys, and trust me when I say this. Please trust me when I say this, because I reached the 150th question Okay, I only had like about 40 or 50 seconds. Okay, and I didn't even read the question. I just directly, take the option, because I hope you guys know that for you to be assessed, you need to attempt all of the questions. All the questions, all 150 questions must be attempted. Okay, if you don't, okay, if your time passes, if your time's up, okay, and if you've not attended all 150 questions, okay, then you can get terminated. Okay, then you won't be even assessed, you won't be taken up for the assessment, and your results, they'll just give you it is insufficient. The data is insufficient, right? So that is what I did. Okay, so like I reached my 150th question. Okay, and I had a lot of crunch with time. The time crunch is real when it comes to AMC. Trust me when I say this, guys. Right? So time management is really crucial. So actually, for one question, I think it's always a good idea to keep a look at the timer results. The timer will be provided to you on your screen, on your computer screen. So have a very good look to the screen as well. Right? You have a look at the timer. Okay, and like maximum what you can go with is 1 to 1.2 minutes each question. Don't go more than that, right? And over here you don't have the luxury of flagging the questions or coming back to the questions. No, because until and unless you don't tick that particular question, you don't answer that particular question, you won't be able to go to the next question. So anyhow, you have to answer all the questions, and you don't have the luxury of coming back to that same question again, right? So you try to read it, or read the question very quickly. See, reading the questions is an art. Okay, so only for this question, right, for the breast cancer, okay, actually your catch was the HER2 and positive cancer. For all the HER2 positive, ER is negative, PR is negative, HER2 is positive. With all the HER2 positive, you are supposed to give trastuzumab, HER2 targeted therapy. Okay, so even if you don't read all this all this nonsense, okay, still the answer would remain same. Okay, so have the habit of reading the question upside down. So first go to what they're asking. What they ask, what is the next step in the management of this question? Then you go upside down manner, right? Do not start the question from right from the very top. Okay, so reading the question is an art. Okay, but try to read the whole question. Don't be in so much haste that you don't remember to read the question as well, because the English of AMC, the people who comes up with the questions and who are formatting the question, I think the language of them is not good, because the grammar is not so good, right? Like the setting of that question would not be proper. So sometimes it'll be giving you the vital information of the question right at the start, sometimes in the middle, sometimes at the end. They'll give you the whole history, and then at the end they'll tell you the patient is pregnant. That is also a very common practice. Okay, so keep that in mind. So you are supposed to read the whole question, right? But just in case, to be very protective with time, try to read the question upside down. Okay, so that you can save on your time. Okay, these are the common challenges: time management, anxiety, stress. Okay, so that you need to work on it, and you can only work on it if you take maximum marks, if you take tests and everything. Then only you can work on your time management skills as well as on anxiety and stress. Okay, this is your key areas to do. While you guys can take I think a screenshot, I think it is available. Okay, all these things I have kept it over here. This is something that you must be devising in your last week. Okay, in your last days of the exam, all these high yield condition, all the emergency medicine questions, ALS, BLS, algorithm analysis, set shock, anaphylactic shock, what is the dose for the epinephrine, when do you administer it, how do you administer it, everything. MI, stroke with TIA. Okay, stroke is very important, transient ischemic is very important, diabetes is also very important, and you must have a file. I think that is also there in the notes for this here as well. You must know for the imaging, so you must go for all the images, and for the images, please give all images which is given in the AMC handbook. Okay, because sometimes they put the direct images which is there in the AMC handbook right to the exam. Okay, so whatever images is there in the handbook, you must revise it in your last leap, right? In your last week for the preparation, please revise those things, right? GYT, all the conditions, have a quick look, because I think in my exam, in my month, and also in the next month of the exams, I think for 3 to 4 months over there. Okay, they asked a lot of gastro. Okay, so 50% of the exam was gastro, and 50% was the rest of the exam, right? So the gastro is very important, gastrology, because in the surgery they don't have much to ask, right? It is only just gastrology or urology. Okay, in the urology, the max they can ask is the prostate cancer, the BPH, the testicular cancers, and all these things. So they have a lot of things to ask from the gastro, right? So you try to revise all those gastric, the small bowel obstruction, the large bowel obstruction, okay, pancreatitis, gallbladder, acute cholangitis, cholecystitis, what are the triads, how do you manage it? Very important. And the esophagus, each and every condition associated with the esophagus, the achalasia, okay, the achalasia and how to differentiate between the types of the achalasia. That is very important. The dysphagia, what are the differentials of the dysphagia? How do you differentiate between it depending on the history and everything? Dysphagia, again, a very important topic. Okay, barium swallow and everything, and what are the findings for the barium swallow? Okay, for the stomach, the peptic ulcer disease, very very important. H. pylori, very very important. Triple therapy, triple regimen, all these things. So the whole gastro is very important. So try to revise through all these notes very quickly. Try to go through it because I think you guys would have taken the notes, the short notes, which is there, right? So try to go through all those things and do not forget to revise the gastro as in whole. Okay, so try to concise. Okay, so for the people who's got exam like in very, very near future, I think it might not be possible for you, but for the exam, for the people who've got exams in the March or in the next month, okay, just go through the gastro. I think for all these systems, this would be my my advice to you, that what you should be doing is that we should be taking the short notes for everything, for what you can revise it in the last minutes, in the last days of examination. And gastro is very, very important. I cannot stress on this factor more. For the obstructives, the ANC PNC care, the hypertension, okay, the diabetes and the pregnancy guidelines, the bleeding causes trimester wise. What is the first trimester bleeding? Okay, so first trimester bleeding can be the ectopic pregnancy or the miscarriage. The last trimester bleeding can be placenta previa, abruptio placenta, vasa previa, right? All these things. So differentiate. How do you differentiate between all these cases? For the miscarriages, for the type of the miscarriage, how do you differentiate between the types of the miscarriages? Okay, which is a threatened abortion, incomplete abortion, missed abortion, complete abortion, or septic abortion. So how do you differentiate between that, depending on the cervical findings and the bleeding and the passage of of the conception, products of the conception, and everything? You must be able to differentiate between those things, right? What are the guidelines for the diabetes and the hypertension in the pregnancy? How do you manage it? What drugs do you give when you do the OGTT, the sugar test? At what weeks do you do the OGTT? In what it is contraindicated? Like this is a very famous question. So for the diabetes, who is at the high risk patient? So it's an ATSI or Asian member, or already a known case of the diabetes. So over there you actually do the OGTT again at the 28 weeks as well, right? OGTT screening is not routinely recommended, but you only do it for the high risk patient. So knowing all these things is very important. For the gynec, bleeding or the causes of the bleeding, the premenopausal, intramenopausal, postmenopausal, postcoital, the postmenopausal bleeding, right? Sorry, it's not postcoital. Yeah, postcoital bleeding. Yes. So what are the causes of this bleeding in all these age groups? You must know how to diagnose it, right? And these are the cancers. I call it five goldens, right? I've repeatedly discussed this in my lectures with the academy. So this is the five most common cancer that you must be knowing, and I've written it in its order of importance: prostate cancer, colorectal cancer, melanoma, cervical cancer, and breast. Okay, and out of these three, these two we already discussed in this short seminar: the prostate and the colorectal cancer. Melanomas, you must be knowing how do you screen for it. Cervical cancer, only screening is important, not management. But how do you screen? Okay, there is a proper guideline for that. And for breast, again, breast is not very important, but you must know the screening guidelines for that. Okay, national immunization schedule, that is also very important too. Wikipedia, right? So these are the key areas to revise. Okay. Now test taking techniques. So when you are taking the exam, so what you should be taking? See, don't overthink. Okay, do not overthink. That is actually your enemy over here. Okay, it's actually going to ruin your exam. So always trust your first instinct. Whatever you think first, okay, keep that in the priority. See, having said that, I'm not telling you to not look at the differentials or not think about the options and everything. Okay, you must think about it. But what is your first instinct? So if you're getting confused, okay, then go with your gut feeling, always and always. Okay, don't waste more than 1.2 minutes in any question. Answer with the closest option and move ahead. Okay, because I have seen people, even though you are taking the mocks, because see, most of the time in the mocks, what happens is in your mock exams, you already have the question which you already have solved. Okay, many times it happens. Okay, so sometimes you'll be, when you're taking the mock exams, sometimes you might finish it before time as well. But when you talk about the actual exam scenario, what happens is you would be falling short of time. Okay, so always be prepared for that. Right, so I have seen people, who could only attempt 140 questions or 130 questions. I know 2 or 3 people who just could only attempt 120 questions, right? So they won't be taken for the assessment. Okay, so your first target in this exam is to attempt all the questions. Right or wrong answer doesn't matter, but your first target, your first thing what you should be doing is first complete. Your target should be complete all the 150 questions. Okay, that is your target. And see, and always never go with extreme answer. Always or never. Don't what do you mean by this? Like, don't be so biased over that as well. Okay, it can always happen like this. It would never happen like this. Be open to the different options as well. Okay, and be very mindful of the traps and distractions. What do I mean by traps and distractors? Okay, this only the next line management, the best line management, the most appropriate management. Okay, they'll change the age group and then your answer will change, like we just did, right? Like for the TAVI and for the atrial replacement, for the aortic valve replacement, so depending on the age, so they might change the age, right? And even see, AMC knows, right, that you guys are taking the recalls. Okay, like say, for example, from the previous weeks, previous months or everything. So AMC knows that, right? So they'll be changing the questions. So always be very mindful for the traps and distractors. Be very mindful for that. Okay. Stress, anxiety management. Okay, so obviously this is something which is common for all the exam. Get adequate sleep before the exam, eat a balanced meal. Okay, deep breathing, mindfulness. If it helps you, then just do it. Okay, but see, be mindful of all the recalls you can get in the last minute of exam. It sucks, but it's very vital. Okay, so be very, need to be active in your WhatsApp groups and all those things as well. If you can have a catch of any recalls or anything, then try to do that as well. Try to grab this as well. Okay, see, this is something that people are still getting confused, right? They're taking exam, but they don't know about these things. This is very basic. Okay, see, when you go into the exam, they'll just frisk you. So actually, you're supposed to face the camera, and then you're supposed to, I'm wearing a shirt right now that I actually, put down my collars and put down my westerns and everything, and I have to show that I'm not covering anything. So it's a very good idea to just go in the t-shirt or very loose fitting clothes, okay, so that your time is not wasted in the frisking. Okay, you only need to go with the two IDs, your passport and any other of your choice. That is all that is required. You do not need an allotment letter. Okay, just go with a passport and anything. Okay, your identification number, your social security number, anything which is there. And this is very important. Empty your bladder right before your exam starts. So after you're done with this verification of documents and everything, okay, well, the center is very nice, and most of them, the center for the AMC is really good. It's a Pearson View centers. They only would tell you that if you want to go to the washroom, just go to it now. Because what the problem here is, if you want to go to the washroom, okay, so and when you come back from the washroom, they'll do all the process again. Okay, you're supposed to face the camera. You're supposed to frisk yourself again. You're supposed to show the passport and all this identification. They'll verify it. They'll do all those things. It's going to waste a good 4 to 5 minutes of yours. Okay, so just empty the bladder and do not drink water right before going to the exam, or while you are taking the exam. Do not drink water, right? And empty your bladder right before you go to the exams. And don't worry, you'll be given the rough sheets in the examination as well, so you can use that as well. You're not supposed to take any of these things along with you. Okay, at the end, just what I can say to you, just trust your preparation, stay confident, composed, focus on scoring efficiently, not perfection. Because see, you guys are knowing this, it's called AMC CAT, right? MCQ CAT. What is CAT? It's a computer adaptive test. Okay, so for most of the questions, there is no one perfect right or wrong answer. What they want to know is the computer would be scoring you, and computer would be scoring you on the basis of what option are you going with, right? So sometimes you're going with a very close option. Like again, I'll take the example of then if you go with the aortic valve replacement, that won't be wrong, right? But if someone goes with aortic valve implantation, then that person, like say for example, if that question is scored as 10 marks, that person will be getting 10, but you'll be getting 5 or 8 or anything, right? There is no specific mark allotted to each question, so you never know how you'll be scored. Okay, so always focus on scoring efficiently. Try to go with more efficient answers and don't just try to chase the perfection over here. Like I only want to go with the perfect answer. If you can grab the perfect answer, it's well and good. For the questions in which you are getting confused, right, just go with the efficient answer. Go with the answer which you got to be, to be the closest answer, right? And you've got this. Please believe in yourself. Okay, I know it's a very the exam which is going to take a lot of you emotionally, mentally, financially, everywhere, right? But you've got this. Trust your preparation. Okay, and thank you so much. Wishing you all the very best. If you guys have any sort of questions, I'm here for next 5 to 10 minutes. Okay, you guys can let me know if you guys have any questions.
Thank you so much, Dr. Chinmay. It was such a lovely session. I guess a lot of students were very worried about their exams, and with your session, they are very much motivated. I must say this thing.
Thank you so much. Thank you. I hope so that as well.
Yeah, yeah, it's really wonderful session. Thank you so much for your efforts and the last minute, session. Thank you so much for this
Yeah.
session today.
Thank you so much. Thank you. Thank you. Thank you. Is there any question? I can. The class is open. Like I can make a few questions and then we can wrap it up. Thank you. Thank you, Dr. Jishan. Thank you. Thank you, Dr. Hasanti. I try to cover all the important topics that is there. Okay, so this topics more or less it will come in your exam. So just be prepared for that. Okay. Okay then. Okay. Okay. Thank you so much. Thank you so much, guys. Thank you so much. Okay. Have a good day. Have a good night. Thank you so much, Dr. Asma, for the coordination and everything.
Thank you so much, Dr. Chinmay. Also, I wanted to let those students who are appearing in February and March exams. So we are offering examic sessions. So if you want to join that, in which we are going to give you the new recalls, so that will really help you to understand what kind of questions are coming in the upcoming exams. So we will be conducting these sessions from 10th of February with Dr. Nilafar Abru. That will really help you to understand the new questions, tips and tricks, and we're going to solve as much as questions as we can before the exam day. And we are going to conduct this session for 5 days from 10th of February till 15th of February. and time duration would be for 2 hours, and timing will be 11 a.m. GMT. So those students who wants to book their session, they can let us know. We have shared our contact numbers. They can contact us. And those students who are not appearing in February or March exams, and they have exams in May or June or July, they can join us for the regular course, in which we have the amazing mentors, amazing faculty. Dr. Chinmay, Dr. Fahad, Dr. Nabila will be there for your guidance. So we are left with only 20 seats. So what are you waiting for? Book your slot so that we can start the preparation together. So that's all for today's session. Thank you so much, all.
Yeah, thank you so much everyone for joining. It was a really good session. Thank you everyone, and wish you all of you a very good luck for your exam. Have a good day, have a good night, and see you all again soon.